Hello. We've never done this before, so we have no idea how it will work, but thank you for joining us to talk about Dupuytren's disease. And I hope you find it interesting, as I suspect you've all got an interest in it, probably in your hand. We got several people on the panel today who I'll just briefly introduce. We got Matt Gardner, who's organizing everything and is the technical expert. Then we got Anna Schurer, who you probably know from the British Dupuytrens-Society, and Ian Arland as well from the British Dupuytrens-Society. Then we have Jeremy Rodriguez, who, like Matt Gardner, is a hand surgeon, and Adrian Chernosky and his wife Debbie. Adrian is a surgeon, Debbie is a hand therapist with a long interest in Dupuytren's disease and looking at its outcome. Then we've got Richard Schaefer, who is a radiotherapist, which I hope you will find interesting. As a hand surgeon myself, I think it's very interesting, the role of radiotherapy and where it goes to go. And then there's me who's talking, I'm Tim Davis. I'm now going to hand you over to Matt Gardner, who's going to give a bit of a description of how to use this webinar and how you can get yourself involved in it.
Thank you very much, Tim. So at the moment, you'll be able to hear us, but won't be able to talk. If you have a question, then there are two ways of asking that. One, you should be able to mouse over at the bottom of your screen and see Q&A. If you click that, you'll then be able to ask a question. We'll then endeavour to either answer it live within the webinar or through a typed answer. Now, if you'd like to speak, again, if you ask a question, then we'll be able to make you go live and you can ask the question and then perhaps engage in some discussion. The other thing is we have a chat room as well at the bottom, and you can also message one another to the whole panel or individual panel members. I would ask you to ideally message everyone so that it's a live message that everyone can see, and there can be some discussion there. So without further ado, I think it's relatively informal. As Tim said, this is the first time we've done it. So there'll be an element of playing it by ear, so to speak.
Okay, we're going to move on. They're going to be short 5-minute talks. And then there's 10 minutes for you to fire any questions you want relevant to that talk, or if there's no talk seems to address the question which you want to ask, you can ask that towards the end. But we're starting with Adrian and Debbie, actually speaking from Norwich, about what is Dupuytren's and some basic facts about Dupuytren's disease. So over to you two.
Okay, thanks, Tim. Is that okay, Matt? Our picture's not up, but shall I start speaking?
Yes, did you have any slides? Or...
Okay, no slides. I'll crack on.
That's fine. Just carry on, yeah.
Lovely, lovely. So a warm welcome, and my role is to give an introduction or an overview of Dupuytren's disease. And so sort of what is it? Well, it was in the 1830s that Dupuytren, a French surgeon, described a disease affecting the hand. And it's specifically the connective tissue layer or the fascia of the hand. And this becomes thickened, forming nodules and cords. Nodules are the tender lumps full of dividing cells. Cords, not to be confused with the flexor tendons that sit deep in the hand, have fewer cells, more connective tissue, and typically shorten, and these cause the finger joints to bend, so you can't straighten them, and the overlying skin contracts. And this is generally the ring and the little finger. So who gets it? Who's our typical patient? And our typical patient will actually be male of Northern European descent with both hands showing signs of the disease. And he'll represent about 3 to 5% of the UK population. Celts and Scandinavians have a higher prevalence, about 9% of men, 3% women. And this is where the term Viking disease perhaps originates from. So when researchers review our patient's family history, he thinks that there'll be somebody in the family with about in 50% of cases, but they'll find it in about 80% of cases. So there is an inheritability to it. It's an inherited disease. The genetic studies of thousands of patients diagnosed through the need for surgery compared with the rest of the population show about 24 genes involved. So it's all pretty complex stuff. And it just simply depends on which ones you get as to how bad your disease perhaps might be. So our patient will show too much connective tissue in these two fingers, the little and the ring, and we call that the ulnar side of the hand. A common question is, what's it affected by? Well, it's affected by heavy manual work and diabetes, probably. Comparing stonemasons to non-manual workers, they get it twice as often. The epidemiological studies, however, are difficult. Their inclusion criteria vary. In other words, is it a hand with a little bit of Dupuytrens or a full-on contracture? And so that doesn't help interpretation. Will my children get it? Well, it's down to the chance which genes they pick up, but the probability is they will get some form of it in later life. Can you avoid it? Well, I suppose if you could avoid heavy manual work, it might help, but rather impractical. And avoiding diabetes is a good thing anyway. And there are no known dietary changes which you can add to help. We sometimes use the term Dupuytren's diathesis, and that's the younger patients, more areas of the hand and other areas of the body. We call that ectopic disease, such as the soles of your feet. The stronger the family history, the more rapidly the disease progresses, and these patients can end up needing multiple treatments in their lifetimes and overall poorer results. So that's the diathesis. So how do we treat Dupuytren's disease? Well, we cannot cure it. The hand cells are wrongly programmed. They make just too much connective tissue, and we don't have the ability to change the genes. Surgery has been the traditional treatment to try to straighten the fingers by cutting out the diseased tissue, and that's called a fasciectomy. The trouble is that many patients will see their bent fingers come back over the years after surgery, and we can't predict this. There's no test or biomarker. The best predictive tool is simply based on your age, ectopic disease, and family history. That's the diathesis, and these patients will fare worse. So surgeons will tend to wait a bit until the finger starts to become a functional problem, showing early contracture. This is where perhaps the complications of surgery outweigh the benefit. And this might, in the long term, reduce the number of operations needed by timing the first intervention. Certainly revision surgery does carry more risks of injuring nerves and blood vessels and can have worse results. Of course, we have commissioning in the NHS today as well. And so some commissioning groups only want you to go to the hospital after a certain angle is achieved. And that's within the UK. Surgeons can replace the skin. That's called a dermofasciectomy. That's skin taken from somewhere else, a much bigger operation, and it takes a lot longer to get over that one. But more recently, the pendulum swung towards limiting surgery with needle release, fasciotomy, and that's been popularized in France, or injected enzyme called collagenase, and that was developed in America. And these outpatient-based procedures are fairly simple in experienced hands. Recovery is quick, get back to work quickly, but they tend to be associated with an earlier recurrence rate. They can be repeated and don't affect if you do go on to have later surgeries such as fasciectomy or dermofasciectomy. These minor procedures, they've been associated with a change in how we review our results. Before, we used to focus on angles. Angles were everything, try to get the finger straight at all costs. Whereas now, we actually ask patients a bit more what their feelings are, and then we rely on patient-rated outcome measures a little bit more. Radiotherapy can target the areas of Dupuytren's disease where the cells are really active, the nodular disease. It doesn't tend to affect the contracture. This is the cords, they don't have so many cells in them. Patients suitable for this are often referred to as early progressive. Now, this treatment was popularized in Germany. Radiotherapy treated groups may go on to have surgery in 20%, no radiotherapy comparison groups in about 50%. So it has some effect. Now, that I've just quoted comes from the Essence study over 11 years follow-up. But of course, that study was performed by the Radiotherapy Centre. So who should I see? Well, there's variability into how and at what age Dupuytren's presents, variability in the patient's needs and wishes, variability in the surgeon's preferred treatment options, and that might be through the results of the treatments they've seen themselves. And so it becomes quite complex. No one treatment is the right one. So I think you've got to find yourself an experienced hand surgeon and talk it over with them. I've got a minute, so I'm just going to talk about frozen shoulder, which was requested on some of the in the questions. This is a painful inflammation of the shoulder, which occurs spontaneously and causes contracture, perhaps a little bit similar to Dupuytren's. Usually, this will resolve itself after many months or even years, but can leave some stiffness behind. But there is a strong correlation with Dupuytren's disease and diabetes. The Dupuytren's disease patients probably have an 8 times more chance of getting a frozen shoulder. Out of interest, in one study
we've lost him.
looking at cancer enzymes with down collagenase and hoping to stop them spread. Some of these patients were given a cancer agent and they developed a frozen shoulder and Dupuytren's-like disease. So again, the relationship was seen, but we don't really understand it beyond that. So there is a link with Dupuytren's and frozen shoulder, but the treatment for frozen shoulder is the same whether you have Dupuytren's or not, and we can't predict it. So that's a quick blast through Dupuytren's disease from my perspective as a hand surgeon in Norwich.
Thank you very much indeed. Okay. Any questions? Any of the participants wish to ask a question? Can I ask, Debbie, can splintage prevent the need for surgery or slow down the time? If you make an occupational therapy splint to hold the finger straight at night, can that stop it progressing and avoid the need for surgery or any treatment?
There have been a couple of small studies looking at that, one that published in 2012 and another just last year, with very small sample sizes of only about 20 to 30 people in each study. And they applied a splint for full-time, nearly full-time, most of the day and night, looking at that. And they also looked at splinting compared to compression, so having a mold put against your hand and secured there, compressing rather than stretching with the splint. And they did show benefits at the end of the study. So between 20 and 40 degrees, compression fared slightly better. But the flaws of the study were that there was no long-term follow-up. We don't know if that means that person has to wear a splint as a maintenance for the rest of their lives. And if they stopped wearing the splint, would the finger contract back down? It's just a bit of an unknown in terms of a long-term treatment. Certainly, personally, I think if somebody chose that, and I have had patients who have chosen to wear a splint as opposed to going for surgery, they felt it was useful and it was something that they wore most of the nights each week as a long-term way of managing their contracture.
Yes. And can I ask if there are no questions from anyone else, I'm hogging it all. Anna, when you went to see a surgeon with your Dupuytren's, or have you seen more than one? Were you confused? Have you come across different surgeons advising different things?
No, because I first developed a nodule when I was 21, and the little finger started to contract in my late 20s, and by the time I saw a hand surgeon, it was quite bent. But that was the first one I saw, and my GP then said to me, there's only 2 hand surgeons in the country, so I'll send you to one in Wrightington Hospital. I don't know where he got that from.
Obviously didn't come from Nottingham.
The consultant I saw knew what it was, but he did call a few of his registrars in to look at my finger, and they all came up with different options.
Okay.
Tim, we have a couple of questions coming through.
Far away.
So maybe this is one for Adrian. Is cracking my knuckles going to cause problems? That's from David.
No, not that we're aware of. So sort of unrelated. And there's some in the chat room as well, actually.
Yes. So, for instance, is there always contracture, or are there cases where the nodules never progress to contracture?
We're simply not sure because it takes quite a long time for the disease to progress, so we can sort of lose track of patients and there's no good studies. So basically one tends to classically start with the nodules. They do not always progress. I'll throw in another one. Sometimes if a hand's injured, it can form a few nodules and they actually don't progress. So the link is unknown. Generally when we do see contracture, patients will have had a nodule, but we can't use it as a predictive tool.
Okay. And then Gary D asks, if surgery carries a risk of return, as does radiotherapy, surely radiotherapy must be cost effective than full-blown invasive surgery. I mean, I think we'll touch on some of this later with Richard's talk, but I wonder whether there are any comments on sort of cost effectiveness of invasive surgery versus other treatment options?
Well, I'll just start from the Essence study. So we know the radiotherapy did reduce the risk of needing surgery, but it did not get rid of that risk. So, and the simple answer is that no large cost-benefit study has ever been performed. Perhaps the closest one we've got at the moment on the go is the enzyme injection versus limited fasciectomy, the Joe Dias' study, and that has a cost understanding. But I'll stop now because Richard, I'm sure, can help.
Well, I'm happy to answer it. But of course, I'm going to be talking about radiotherapy in a little bit of detail, but I think it's fair to say that we just don't know the answer. The studies that have been done on radiotherapy versus not giving radiotherapy have been done in a specific group of patients where they are progressing. So having a nodule and that nodule not progressing would not be a patient that would be treated with radiotherapy anyway. So I think to start with, you have to define your groups. I mean, the other thing I will say is in that study, in the control group where they didn't give radiotherapy, and that's all patients who had progressive disease in the last 12 months, about 60% of them did progress further, and about 30% of them needed surgery without radiotherapy. So I guess the interesting thing to say is there was a significant number of people who, before the study started, were progressing and then did not progress further. So that's interesting. And also, even though 60% progress, only half of those actually needed surgery. So obviously, they might have progressed in terms of getting more nodules and so on, but they didn't progress so much that actually they had a contracture that needed surgery for a functional deficit. So, you know, it really depends what question you're asking, actually, as to, you know, whether you need treatment or not.
Okay, Tim, I'd just like to bring in David, who would like to ask a question. So I'm going to allow him to.
Great.
So
hello?
David, you're now live. Yeah.
Hi. Hello. Yeah, I can't see anybody.
Yeah, we can hear you. We can hear you live and clear.
Yeah. I had radiotherapy 12 months ago on my hand and my boot. I asked a question earlier about cracking my knuckles because I have one cord that has come back to life, for a better word, and the only way I can seem to relieve it is by cracking my knuckle several times a day. I don't know if I need to go back and see Richard again, or do I leave it alone, and I don't know what to do.
I mean, as far as I know, cracking knuckles does any harm, and I think with Dupuytrens, I mean, there are real problems with doing any research in it because everybody's behaves differently. Some doesn't progress for years, some progresses very rapidly, and that's why we're all so confused, myself included, as to what is best to do. But my tendency, and I'm quite happy for Richard to smack my knuckles later, the radiotherapist, is to say, if it isn't interfering with your function and you can still keep your hand reasonably straight and it's not a big problem, then my advice to any patient who came to see me would be, do you really feel anything needs to be done with it at the moment?
Yeah. Well, I'm absolutely petrified because I've had double frozen shoulder, I had Patrones, I've got lederhose, and I really do not want any kind of invasive surgery because I know that if I have surgery, it's just going to aggravate absolutely everything. So I just want to know that if by cracking my knuckle to relieve the pressure on my cord is not going to cause any aggravation as such.
I am not aware of it doing any harm whatsoever. Does anybody disagree?
No.
I guess, sorry, I don't disagree. But what I would say, David, is that, I mean, a few things to say about reirradiation. First of all, there's no proof that reirradiation works, although my practice is to consider it when there's sufficient time from the first irradiation to the recurrence in terms of radiation tolerance. So You know, there are some things we know something about, and there are some things that we intuitively think might be a good idea, but don't really have very much proof about. So I do tend to re-irradiate if there's at least a year gone past since the initial irradiation. But I guess, you know, the other question is, you know, is a good one. I mean, to some extent, I'm in the business more of prevention rather than cure, in terms of trying to prevent a contracture rather than wait for a contracture to form. And so there is a question about timing. And so even if I were to re-irradiate, it is actually a very difficult question, and something really that I don't have a good answer for, and I literally sit with the person's hand in mine and discuss it with them, you know, because it's sort of something I need to work out together with each patient, and there's not a rule book.
Okay.
Perhaps we should move on to the next talk, do you think? And then there are some other questions coming in, but they might fit nicely after
Jeremy.
the next one. Can I just, before we start with that, perhaps we have a poll, and we'd love it if attendees might just let us know what experience you've had of treatment for Dupuytrens. So again, this is the first time we've done this, but I'm going to click the poll now, and I hope you will be able to see it. So perhaps we'll just give that 20 seconds. And please, if you feel comfortable doing it, let us know what experience you've had. There are some other questions coming through. They're coming thick and fast now, and we will get through them all. Ideally, as many of you have done now, if you ask them in the Q&A, it means that we can keep track of them and make sure that they're appropriately answered.
Okay.
Thank you very much.
So while you're completing the poll, I'll just introduce, Jeremy is now, I think, going to talk about various surgical options for Dupuytrens and what they involve. So Jeremy, are you ready?
Yes, I'm ready. I'll start a little bit, and then what I was going to do when we finish with the poll, I'll put up a couple of slides. So I'm going to talk mainly about the surgical options for Dupuytren's disease. And let me just pull up these slides and see if this helps with what we want to talk about.
Yeah.
So hopefully people can see my slides. And we've got a poll here, which I'm just going to move out of the way at the minute. So the treatment options that we're commonly coming across that are delivered by surgeons involve either removing disease, which is what Adrian mentioned, or trying to divide the disease. So here's a cartoon drawn by actually one of the hand surgeons in the Hand Society, and it shows a hand with some Dupuytren's disease affecting the little finger, and you can see the cord that Adrian mentioned here, which is pulling the little finger up. Now, your approach could be to try to remove all of this cord of disease, which would be one of the first two options, or to try and just divide it in place, like snapping a rope on a rock so the finger can straighten, but you've not actually taken anything out. So I'm going to aim to talk about the first two. And the distinction really between them is how you close the skin afterwards. So in both cases, these tend to be performed in an operating theatre, and you would typically have a general anaesthetic, so be asleep, or have the arm frozen with a block, some injections in your neck, your armpit, and the whole arm goes numb. And what that then allows the surgeon to do is to open the skin with a cut, and then remove the diseased tissue. Now, in the case of a dermofasciectomy, they then borrow a piece of skin from elsewhere, maybe higher up on your arm, and they take out the skin and the disease, and they put the new skin graft in it, so like a piece of wallpaper. The thing about that is, obviously, the skin that we borrow from elsewhere, if you look at the skin on the back of your hand or up your arm, is different from the very special skin on the palm of the hand. So it does leave a patch that tends to be noticeable. Otherwise, if you peel the skin back in a zigzag kind of fashion and you scoop out the diseased tissue from inside, then you can stitch the skin back in some cases. The choice between whether you put a skin graft or not will vary on a variety of factors, and that might be whether you've already had multiple operations before and therefore the skin is damaged and scarred already, or if you have a very aggressive trait, a tendency to recur, as Adrian mentioned, this diathesis, then that may also be a reason why people might consider putting a skin graft rather than stitching your own skin back. And part of this is about where the level of the disease is. So this was mentioned. Here's a cartoon kind of schematic of what's going on. So from the outside, we have the skin on the palm of the hand, and then the very deepest layer inside your hand, we've got the bone. And next to the bone are the tendons that bend the fingers. So those run in little tunnels. And then they're separated from the skin by a layer of fat. So that when you push on the palm of your hand, there's some cushion, there's some bounce. And there's a fatty layer with nerves and blood vessels. And the disease is actually sitting in this kind of layer. So because it feels hard and it feels like it should line up with a tendon, sometimes people think it's the tendon that's affected, but it's actually just sitting above that, really. So if you cut through the skin and peeled it back, like peeling open a banana, then you could take out the tissue inside and then replace the skin of the banana. Or you could take the whole thing out as a big block and then put a skin graft in its place. So those are the operative options that we're talking about in terms of what you actually do in the operation. Afterwards, what tends to happen then is you have a dressing on your hand and you'd go home usually the same day in the NHS. And you'd be brought back to a clinic several days later, and they'll take the dressings down and have a look at how things are getting on, how the healing's getting on. And then you usually begin some hand therapy, and it would take several weeks to recover. As Adrian said, that can vary depending on whether you have a skin graft or not. And you may also be given a splint in some cases to wear often at night time. Now, there have been some questions about how effective these kinds of surgical operations are. And there have been some trials in this area, some from the Netherlands. Now, trials are very useful because they're very carefully controlled studies. So we get really nice scientific answers to questions. We get data that people can quote, but they don't always mimic what happens in real life. And it's, I suppose, a bit akin to having a school inspection where there's an inspector in a class and all the class sit quietly and behave far better than they usually do, or alternatively, they might act up. You don't quite know. But the point is, sometimes in a trial, it's hard to predict what then happens in daily life. But what we do know from trials is that there's a bit of a balance from the effects of these kind of operations. So if you have a fasciectomy, on average, it normally will, across all comers in a trial, straighten the finger by about 80% on average. So that means that a lot of people, the finger will straighten out quite nicely. Other people, it may nearly straighten, and there will be some people that doesn't really straighten at all. But overall, on average, it tends to straighten quite a bit. Now, there have been some questions about what the recurrence rate is, how likely it's then to come back. And from the trial in the Netherlands, when they followed people up after 5 years, they found that in 1 in 5 people, so 4 out of 5 people, it didn't come back. 1 in 5 people, it did come back. And that was after a fasciectomy with the skin stitched back. Now, that's much lower than after the needle treatment, where it's much more likely to come back. But the devil is in the detail, really, here. When they reported that figure, that was in people who had had the finger successfully straightened. So you have the operation. In a lot of people, the finger goes straight, and then they measured in how many people it came back. If you had the operation and the finger didn't go straight, then you weren't included in that statistic, which means that depending on your viewpoint, if you're one of these people who your finger doesn't go straight after the operation, then to an extent, the figure doesn't really apply to you. There are some other points really to think about with recurrence, and part of it needs to be, well, how straight does a finger need to be able to get on with things in your daily life? And I put it to you, if you look at the fingers of the Ireland rugby team who beat the All Blacks at the weekend, a lot of those people's fingers will not be very straight at all, and yet they're playing, at a sport, catching and throwing balls all day long with no problem at all. It's not limiting them in what they're doing, and that's probably because of injuries and so on and so forth. And then what is recurrence? I mean, is recurrence a bend of a few degrees? Is recurrence a bend of a lot of degrees? Is recurrence having a bend and then wanting an operation? Because bear in mind that some people who have a lot of problems say, it doesn't matter how bent my finger is, I don't want an operation. So do we say that they haven't recurred even though their finger has bent right back down? So part of it depends on what you want to call recurrence. what we do know is from that trial, of the 9 people who had had a fasciectomy, the finger went straight and then it bent back, only 4 of them chose to have it treated again. 5 of them said, "I'll just leave it alone, thanks." And of the 4 that did want treatment, none of them wanted another fasciectomy. They could have potentially had another fasciectomy. They actually all chose to have the needle treatment. So that may just reflect their experience of it. And certainly when we look at some data from the UK that Tim and I collected, this was from day-to-day treatment in the NHS. So it's not as neat and tidy as a trial. So there's all sorts of other issues that may affect the data. But we did look at all comers. So we didn't just include the people who went straight and then bent back. We included everyone. And we found that at 5 years, about half the people had either a bent finger or had another operation. So that's a much higher rate. Now, that might be that we included people who'd had several operations, all sorts of business, but it just shows you that these, you know, as with statistics quoted by politicians, it can be a little bit tricky, and you've got to really read the fine print to see whether the statistics apply to you. The other thing that I wanted to just touch on is this idea that in the past, we've always been very interested, as Adrian said, about straightening fingers, but there's more to it than that, which is that there can be unexpected effects. Either problems or complications, as they're often called. So, for example, if you have an open operation under general anaesthetic, rather than one of the less invasive treatments with a needle or an injection, you are more likely to have other unrelated type problems, like a numb finger afterwards, or a finger that might go straight but doesn't bend so well, so that you struggle to make a fist. And also, obviously, there's this recovery period that Adrian mentioned. It does take time for things to settle. So you do have to bear in mind that aiming to just get a straight finger at all costs may be associated with other issues that need to be balanced up. So there's an awful lot of different issues swirling around in this decision. And I think this is one of the major reasons why you might go and see 2 different people, 2 different hand surgeons, and get 2 different opinions. It's a bit like asking 2 different salesmen who work for different car companies, which car should I buy? And one might look at, you know, the top speed, and the other might look at how many seats and how much luggage space there are. There's all sorts of different factors that can influence decisions and lead to different recommendations. So I think, you know, what Adrian's recommended is very sensible. Probably what the thing to aim for is to see somebody who discusses a range of options with you. Bear in mind that they might be better at one or other of them, because, you know, surgeons do have different levels of experience, different personal opinions, and different volumes of practice. So one person may do a lot of one operation and less of another operation. But what I would have in the back of your mind is you need to consider what's going to be most suitable for you. So do you need a quick recovery? Are you self-employed and want to get back to work sooner rather than later and minimize time off work, even if that means accepting there's more likely to be recurrence? Do you want to minimize the chance of having to have future treatments? That's the alternative. Maybe you'd rather have several weeks of recovery now and try to avoid coming back to see a surgeon in 2, 3, 4 years' time. Or would having a stiff or numb finger be more of an issue than having a slightly bent finger, even if that means a recurrence of the disease? These are all very personal things. And we are trying to move towards, you know, what we call patient-centered decision-making, or even shared decision-making, where rather than turn up and just be dictated to of what treatment would be best for you, really it's worth bearing in mind that any clinician who sees you in the hospital probably doesn't know that much about what you're doing day to day in your normal life, how much it limits you, how much these problems would limit you. And you really need to bring that information to the table and weigh up the recommendations that they're giving you. Just like if you took advice about buying a car, you wouldn't just take the salesman's word for it. You would think about whether the car is actually going to be suitable for you, whether it's going to be affordable for you, whether it meets your personal needs. So that's really what I wanted to say at this point, and hopefully that's provided a little bit more information about some facts and figures, and also some of the challenges that we all have for patients, but also for clinicians, of interpreting what these different statistics mean. So thanks very much.
I think that sums it up very well. It is very confusing to know what to do. Every surgeon tries to do his best, but they may not all agree as what is best, driven by past experience, or, as Jeremy says, interpretation of what they have read and seen. So, Matt, other questions? Your microphone's off.
Yep. Yes, we've got 7 questions at the moment. I think perhaps we could work our way down them. David says, what treatments are actually available on the NHS, and are they uniformly available in all areas? Obviously, Jeremy's been through the surgical options. I wonder whether Adrian, Tim, you might comment on the variability around the country in terms of perhaps CCG guidelines, and that feeds into another question a bit later on, where Peter asks, in general across the NHS, is it true that they won't pay for anything until the Dupuytren's contracture is more than 30 degrees?
Can I quickly deal with the surgical and let Richard do with the radiotherapy?
Yeah.
With the surgery, there's the NHS England, so this doesn't influence Wales or Scotland, is trying to get all the indications for surgery for Dupuytren's to be the same throughout the country, so that where you live doesn't affect what's offered. And it is, I was at a meeting where that was being bashed out in London last month, and it was very interesting, but they will everywhere offer the needling, the surgery, and with specific criteria, collagenase. And those look as if all 3 of those will be available from the surgery. But there is the limit of it's all based on your angles of how bent your finger is to get past the goalpost to be referred, to be considered for surgery, which, just because the indication which the government says is 30-degree bend, doesn't mean to say you may necessarily want it at that time, but you can be considered for it at that stage. The choice is still yours. So that's with the surgery. Richard.
Yeah, so in terms of radiotherapy, this is a pretty hot topic, and I think it's fair to say that it is not universally available on the NHS. When NICE looked at it in 2011 and then last year or the year before, basically they said that they didn't have any issues with it, but they didn't feel there was enough evidence to support it in a widespread way in the NHS. And so there are some areas that have taken the view that they will support it, and they offer it generally on a fairly small scale basis, but I'm sure it's different in different areas, and there's a lot of areas in the UK that do not support it. I know that on the British Dupuytren-Society site there is a list of places where you are able to at least ask for radiotherapy. So the answer is, I mean, it's available in some areas and not others. And I think really the reason is, certainly when I tried to get it supported in my own area, is that it was felt that there was a lack of evidence in the sort of formalized way that would be demanded for funding a large scale treatment that obviously would need a large amount of funding. I mean, I can talk about levels of evidence in when I talk myself.
Gary had a follow-up question, which was really to the hand surgeons, asking whether they're in favour of radiotherapy as preventative or preemptive treatment, and are there conflicts of views around that? I wonder whether Tim or Adrian, you have...
Adrian wants to go.
Yeah, so I'm lucky here that I have a good oncology service and I can refer for radiotherapy. So I will tend to offer radiotherapy to those patients who have lots of big angry red nodules in their hands, only very early contracture. And of those that I offer it to, probably just under half would want a consultation with the oncologist. For just over half, that they just don't really want to know about radiation. That's their sort of view. So I do refer for it, but the number of patients I'm referring is only a few each year.
I think it's fair to say hand surgeons are coming around to it. Whereas about 10 years ago, there was great concern about the risks of radiotherapy. Richard actually spoke to the British Society of Surgery of the Hand in London a few weeks ago, and I think scored quite a few converts. And to be honest with you, I wouldn't mind if I never had to do a revision Dupuytren's surgery. So if anybody could show to me that if you get recurrence after a surgery, that if you, after surgery, you could prevent recurrence by giving radiotherapy, I would be overjoyed, and so should you if you're a patient.
Yeah, and I will add that there are trials going on at the moment in a very formalised way. So, as I say, I'll talk about it in more detail, but essentially there are flaws in the evidence, and people are now setting out to do that evidence gathering in a much more randomised, formalised way to actually get the answer, both in this sort of early progressive disease setting, but also post-surgery. And I think once that trial reports, we will know definitively what the answer is. At the moment, we can say intuitively, or that there's, you know, good evidence, but we can't say there's definitive evidence.
Okay. Matt, how are we doing for questions? Somebody has asked, what are the chances of losing my finger? My hand is awaiting its 4th operation. But that is, what, speaking informally, if I can just answer that, is I think with the more operations, and if there's anybody I have who's having recurrent operations on the same finger, the risk of losing the finger goes up with each, and because of loss of blood supply. So in an initial operation, the first operation on the finger, it's very low. With a revision, it is higher. And then if you have further revisions, yes, there is that risk going up and up.
Tim, there are a few questions, but I wonder whether we move on to Richard, yes, and then we can perhaps...
Yeah, I think we should do Richard, and then we should answer whatever questions there are. I was going to talk at the end, but I don't mind being dumped. Richard, we're far more interested in you.
I'm sure not. Okay, so I do have some slides, and I'm going to attempt to share my screen. So play from the start. There we go. Right, can you see my screen? Sorry to ask this while I'm doing it.
No.
I was hoping to. That's surprising. Right, share. Can you see anything there?
So Richard, are you clicking share and then select the program you wish to share?
I see. Okay, yeah, sorry.
So you
yes.
have to click the window. Yep, so we can see that now. Yep.
Fantastic. Okay, so I've got 6 slides. I'm really just going to talk about some very basic things to do with radiotherapy. So I'll start off, what is radiotherapy? Radiotherapy is the use of radiation for the treatment of disease. Generally cancer, we use high doses, and we use lower doses to treat non-cancer conditions. We generally use X-rays to get to the skin. It's low energy X-rays or electrons. I wouldn't get too sort of worried about the difference between those, but we can talk about it if we need to. Okay, so who should get radiotherapy for Dupuytren's disease? Well, just to sort of bring in the concept of what I would call early Dupuytren's disease. And so obviously we talked about the fact that you have nodules, you have proximal and distal cords, so proximal going sort of up the arm, distal going towards the fingers. So that is really, and also something called skin retraction, where the skin gets sort of pulled by the disease and you get pits in the skin. So that all forms early Dupuytren's disease. When you get more advanced disease with a contracture, then radiotherapy really isn't useful at that point. So the patients who I recommend for radiotherapy have, as I say, early Dupuytren's disease, either no contracture, in other words, a straight finger, or a very early contracture of less than 10 degrees. And it has to be getting worse. So someone who's got a nodule there that hasn't changed over the last 10 years, they just don't necessarily need any treatment, and they may never need treatment. And then there's this group we've touched upon already, where perhaps they've had a release either with surgery, needle aponeurotomy, or with collagenase. And intuitively, one thinks that perhaps they might benefit from radiotherapy afterwards, potentially to combine a fairly non-invasive treatment, like with a needle, for instance, with radiotherapy, so that you get the fewer side effects, but also reduce the chance of a recontracture. So I'm sorry, I'm having a lot of trouble controlling this. There we are. So what's the process? So you would see the doctor, and I would take a history, examine the hands, make sure that the history is compatible with having progressive Dupuytren's disease, and also actually diagnosing Dupuytren's disease in the first place. If we decided that it was something that you wanted to do, then I would mark up literally with a felt tip pen on the skin. This, by the way, is taken from the internet from the German group. And you can see that they've marked some nodules, they've marked a chord, and then the straight lines is basically a representation of what they're actually going to treat. And the implication is that the rest of the hands, they will miss out. And so this is both hands has got some disease. They're treating the right hand, it's more severe. And you can see also that they're treating the foot, which you can either call Dupuytren's disease of the foot, or plantar fibromatosis, or Lederer's disease. And that can be used to reduce the nodules or reduce the pain in them. So I mark it up, and then we take some photos and make a template. When you come to treatment, it lasts for about 10 minutes a day. It's painless, and it's just like having a scan with x-rays. It doesn't make you feel drowsy or dizzy or nauseous. You can carry on doing anything you normally do, like driving, normal daily tasks. Although people who do really difficult things with their hands, like lifting weights, going sailing, and having lots of friction on their hands, or very difficult manual tasks, I do tell to stop after each week, to stop doing those things for about 4 weeks. And one of my patients described it as painless and unspectacular. I thought that was quite a good description. Although actually unspectacular feels a bit of a shame to call it that, but anyway. So then in terms of what we actually do, as I say, it's 10 minutes a day. There's 5 treatments over 1 week, Monday to Friday, so it's weekdays, consecutive weekdays. There's a gap of around 3 months, although different people give different gaps, and I don't think there's any proof really that one gap is better than another. We can talk about that in more detail. And then a further 5 days of treatment over 1 week. And so this is, so it's 15 gray, which is the radiotherapy sort of dosing, 15 gray in each phase, so that's phase 1 and phase 2. And then, so the total dose is 30 gray and 10 fractions, a fraction being a treatment. Right, here we are. So this is the slide really where I've sort of summarized the results. There are later results, but I find these easiest to remember. So the results by 8 years. Now, it's worth bearing in mind that the German group who did this study, rather than saying, we've got a treatment, I wonder whether it works, in fact, they said, we've got a treatment, we know it works, let's just try out 2 different doses. And that was a bit of a shame, because that trial was never going to prove whether it was better than nothing. So where I've put radiotherapy, in fact, they tried out 2 different doses of radiotherapy, which there were minor differences between them, but not such a difference. Now, the no radiotherapy arm was not a randomized arm. So they didn't say, let's randomly put you in a group getting radiotherapy or not getting radiotherapy. But there was a group of patients who went into the trial and were supposed to be randomized between either getting 1 dose of radiotherapy or another dose of radiotherapy, who said, look, actually, I've decided I don't want treatment. And that was the control group. And there are about 100 or 200 of those patients. So they were a control group. They were people who didn't get radiotherapy, but they were not randomized into that group. And therefore, you don't know whether perhaps the results of the results that came from the radiotherapy and the non-radiotherapy group that were different were a result of actually the group themselves being different rather than the radiotherapy giving the difference. In other words, they had different baseline characteristics. But anyway, that said, there's no particular indication in the study that they were significantly different. And these were the results they got. So this is, so where I've put worse, what I mean is between the 2 groups with no radiotherapy and radiotherapy, those who did not have radiotherapy, 62% of them got worse. Now, worse meant either increasing nodules, increasing symptoms, more nodules, more cords, contracture, or needing surgery. And so without radiotherapy, 62% of them got worse. with radiotherapy, about 20% of them got worse. So it reduced the chances of progression or worsening of disease by about 3 times. And then in the last column, you can see that there's surgery for contracture. And again, coming back to the point before, this is not who actually got a contracture with either no radiotherapy or radiotherapy. It's those who actually had surgery. And with no radiotherapy, 30% of people had surgery for a contracture. With radiotherapy, only 8% of people had surgery for a contracture. So you can see that there was a reduction by about 3 times again of those having surgery for a contracture. So those are essentially the headline results of radiotherapy. And then in terms, oh, it's gone. So I'll go back on the slideshow. Onto the last slide, if I can. Oh, right. Having trouble here. Okay, so anyway, my last slide was really looking at the side effects. And basically, the side effects of radiotherapy tend to be very minor. It tends to be on the skin and redness and soreness and a bit of dryness. It's what we call grade 1. In other words, doesn't really need any treatment for it. For most people, that will go by a number of weeks after the end of treatment. But there's about 15% of people that have ongoing dryness or changes in the texture or colour of the skin. So they have ongoing grade 1 problems. There's also the risk that people get very scared about, and understandably, that radiotherapy, as well as being used to treat cancer, can also cause cancer. Now, it's difficult to find out what that risk is, because in fact, there's never been anyone actually written about in the literature where they've actually got cancer, but they've worked out the risk from information from nuclear disasters and nuclear bombs. And basically, they worked it out from people who actually died from cancer when they had a radiation blast. And from doing some various calculations, the risk really is of skin cancer, which tends to be something that you can actually cut out with surgery, and probably is in the region of perhaps 0.01% lifetime risk. Although I quote my patients up to 1% lifetime risk, just to be cautious. So it's a low risk, but certainly it's a risk that you have to discuss, and particularly with younger patients, because they have many more years to live, there is an increased risk. So I'm a bit more concentrated on that for that reason. So that's my little talk. I wonder whether we have any questions.
Yes, Richard, there's one from Paul Edwards, and I'll just see if he'd like to ask it himself. Paul, you're live, if you'd like to ask your question. I think he's muted himself, so I'll ask it instead. So Paul says, it's pretty much accepted that radiotherapy is not able to help patients where the disease is established over many years and it's extensive, particularly where previous procedures have resulted in a buildup of scar tissue in these old surgical areas. However, comments from sufferers on the Facebook support group British Dupuytren-Society suggest that many are having radiotherapy, perhaps after needle aponeurotomy or Xipex treatment. I believe that there is also a large trial on radiotherapy treatment at the stage taking place in Australia next year. Given these examples, can it be assumed that previously treated areas are stabilized by past treatment and that the areas continuing to develop can be cast as new? If this is the case, how likely is it that radiotherapy would work in resisting the progress of these new areas, thereby making it a viable option? Over to you, Richard.
Okay, thank you. So I think there are a few points there. I guess one is about retreating the same area with radiotherapy. I've touched on that a bit, and that's mainly to do with tolerance of radiotherapy. And the skin and the underlying tissues do regain some radiation tolerance over time, which is why I give, just intuitively, I think a year or so after the initial radiotherapy seems reasonable. And the other thing is, of course, if you've not responded to radiotherapy the first time, then it doesn't really make sense if there's been a very, very short interval between the first radiotherapy and the recurrence to then give it again. I think another point is about giving radiotherapy after a relatively non-invasive treatment, such as needle aponeurotomy and Xiapex. And so I think it's fair to say there is actually zero evidence out there at the moment to support that. Intuitively, it makes sense. And I guess I feel that because these release procedures, as you could call it, in some ways are traumatizing the tissues around there. And we know that trauma is one of the risk factors for progression of disease. And certainly I've given a lot of radiotherapy for people with keloid scarring, which to some extent does have some characteristics in common. And so my feelings would have been that if you can give radiotherapy after the release fairly soon, then it may well be that it reduces the chance of it coming back. I have actually written and produced an abstract for the European conference looking at my results. Unfortunately, it's not conclusive enough really to say anything that's worth sharing at this point, because it was only 10 patients. The follow-up is relatively short. But there is this Australian study. Now, they're doing it in quite an interesting way. What they're doing is, whether you have surgery, Xiapex, or needle aponeurotomy, they want to give the radiotherapy the next day to full dose. And I think that's giving, it's a good way in terms of, if it's going to be effective, you're certainly not doing it too late. But I do feel that perhaps some surgeons might find that perhaps problematic in terms of whether the scars heal. So, I mean, it remains to be seen whether it's effective, and it remains to be seen whether it's toxic. I don't know whether I've answered the question or not, but there we are.
So I think Gary's got a follow-up question.
Richard, could you take your slides off the screen?
Yeah, here we are. Yeah, sorry, I was struggling with my system. Sorry about
that. Gary D says, thanks, Richard. Can I ask a potential daft question? No questions daft. Not about side effects and by inference. I'm sure you have answered this in your presentation, but can radiotherapy worsen the actual disease and make it more aggressive, for example?
So, I mean, the evidence shows that with radiotherapy, there's less chance of progression and less chances of needing surgery for a contracture. I mean, I can't tell you whether there is a very small subset of patients, perhaps within those who progress, that perhaps the progression is worse, but it doesn't. I mean, there doesn't seem to be any evidence in support of that assertion. So, I think the answer has to be no. There's no evidence that radiotherapy worsens disease.
Okay, and Hannah has a question. Is there any evidence to suggest that radiotherapy would make surgery more complicated if surgery was needed as further treatment?
So I think that's a really good question. And there is no evidence, no. And I think rightly surgeons are worried about this. And when I was talking at the hand surgeon conference, I think at that point I did bring up an example of people who have cancer of the rectum, and it was proposed to give radiotherapy before the surgery to reduce the tumour before the surgery, and therefore make the surgery easier to do and potentially increase cure rates. And the surgeons were really worried about that prospect in terms of whether their surgery might go wrong, in terms of various things breaking down, or their scars or internal scars sort of breaking down. In fact, that was not the case. And that was with a much higher dose of radiotherapy. So, I mean, there is no evidence that radiotherapy increases complication rate. So, you know, no one's really looked at it. Again, the Australian trial may well be able to look at that in more detail, and I'm sure it will.
Great, thank you very much. Tim, there was a question we thought might be for you from Gary. He asked, what is happening with the recent consultation where any treatment for Dupuytren's disease was being considered, was considered being dropped?
Yeah, there was a very unfortunate BBC 4 broadcast on this announcement by the NHS England, stating that they were trying to get rid of operations which don't work, and Dupuytren's was mentioned in it, and it was also in the Times, and it was total misconception by the people who were running the procedure. I mean, Dupuytren surgery is better than doing nothing. And if you've got a contracture, is really the only thing which can be done at the moment. I don't think it's, when I left that meeting, it didn't seem to me that they were going to ban it all by any means. And actually the Hand Society have told them what we think the indications for surgery, consideration of surgery should be. So I don't think you need to rush out tomorrow to get your Dupuytrens done. I think it's here, well, I think Dupuytren surgery will be here for a long time until a cure is found so that it's no longer necessary. But at the moment, it's the best we have for advanced disease. I'm not saying it's nice to undergo. I think one of you called it a stomach churning procedure, and that made me think of one of two of my patients who I think felt that way as well. But there's nothing else on the horizon that I know for advanced disease, and I think the surgery will continue to be offered in the NHS England.
Excellent. Thanks. So we have got 2 questions left. I realise we've hit 9 o'clock, but I imagine we could just finish off those 2 questions. Do you think?
Mm. Yes.
So Stephen asks, is there any evidence or experience that surgery may lead to a more aggressive recurrence of Dupuytrens? And as Prof. Davis may have suggested, and if I understood correctly, is there any evidence of using radiotherapy sometime after surgery as a means of reducing this recurrence? So perhaps that's a double whammy from Tim and Richard.
I was going to pass it to Adrian.
Oh, Adrian.
You're on, Adrian. You're not on. Your microphone's not on.
Sorry, just unmuting myself. Right, is there any evidence that surgery can lead to a more aggressive recurrence? We see a flare sometimes after surgery as the scar is healing. And the patients with a strong metastasis, that flare can be quite bad. But once you're over that, I would say, in my opinion, I don't think surgery makes it all worse, unless, of course, you hit a complication, such as an infection or a pain syndrome. I think in regards to the radiotherapy much later, after surgery, then I would agree with Richard. But I can't see that making so much difference. I think that's just radiotherapy being used in effect as a primary tool rather than some form of adjunctive procedure.
I think supporting what Adrian's saying, there's one paper from Neil Bulstrode in the 1990s, who is a surgeon who did some research that did suggest that, in keeping what Adrian's saying, that the biology of your disease can be stirred up effectively by surgery when they took further samples. I mean, it's a pretty small study, it's hard to be conclusive, but that would support what Adrian's saying. And that's the only evidence that I'm aware of. But it's obviously a little bit difficult to conceive, because the only way you're going to get a recurrence is if you had a treatment. So whether that's it can't really be a more or less aggressive recurrence, because it's the only recurrence you'd get. The only way you get to that situation is by having a treatment. But does it potentially change your disease behaviour? In theory, there's a little bit of evidence that it might do.
Richard, are you going to come back in?
Yeah, so just to say, I guess if we think about it in wider terms, then if you remove a plantar fibroma, then quite often that does, in other words, a nodule from the foot, then that does stir up the disease, and often people do get quite bad recurrence in their feet. I've certainly seen quite a number of patients who've regressed having surgery, and I've seen the odd patient who, for whatever reason, has had a nodule taken from their palm, where it's just the nodule that's been taken away, and that stirred up the disease, and they've sort of got a contracture relatively soon after that. Whether that's, it's just anecdotal, but the fact that it does make the disease worse in the foot, it does make me worry about removing nodules, put it that way. I mean, obviously, if you're having, a fasciectomy, that's a different story, really.
Excellent, thanks. We have one other question. I wonder whether anyone could comment on Patrones and the current treatment options available. I'm not sure who would be best placed to answer that.
Can't at all.
I'm not familiar, I'm afraid, with.
Sorry, yeah, we don't have a urologist with us, do we?
No.
I think
But I think
it might be best if whoever answered the question emails me, and then I can put them in touch with someone who can give them some more information.
okay, excellent. Thanks, Anna.
There was a question about gloves to prevent Dupuytrens. Do our occupational therapists know about it?
Yes, I think that was answered, but maybe
Okay.
Debbie could.
I was interested to know.
So we've used the gloves with a collagenase study that we ran down here. So I'm familiar with the fixed gloves, and they are recommended by the manufacturers of Xiapex to use after you have an injection. But they haven't been picked up here in the UK, mainly because of the evidence for splinting in general, or any sort of support after surgery hasn't shown that it made a difference to having a straighter finger compared to not wearing anything at all. So it hasn't really been picked up in the UK. Does that answer the question?
I think so, yes.
Thank you. Yeah.
Ian, you've been very silent there. Do you want to make any comments?
I suppose only to say that from a surgical point of view, I'm a fan of the needle aponeurotomy, and perhaps on a future occasion we might cover that in a bit more detail.
Yeah.
I'm just waiting to go for another session, having had it twice in the past. But I was interested in the comment on whether or not any form of surgery instigated the disease to become more active. And the first time I had NA, I got absolutely nothing afterwards and was a happy chappy. But the second time, I could tell within a week my Dupuytrens was tingly. And to me, it felt very much as though the NA had set it off again. And on that particular finger. But that's just, my experience.
Yeah, I think we've passed our time and we don't want to bore you all. I found it very interesting, and I thank everybody who's asked questions, and thank the panelists as well. And please give Anna feedback. Was this interesting? Did we answer the questions you wanted, or did we go off at tangents to things which bored you? Just let us know, and maybe if you want it again, well, I'm on for it. I've enjoyed myself. I've learnt something. So I think we're closing now. So thank you, everybody, for coming, and have a good night, what's left of it. Good night.
Thank you. Good night.
Last month, we had a webinar where you heard talks on the general nature of Dupuytren's disease and its treatment with surgery and radiotherapy. You were to have heard from me about research into Dupuytren's disease, which is occurring in the United Kingdom, but we ran out of time. I'm going to give this talk now, but it was recorded at a later date, and I'm afraid there's no chance to ask me questions. I'm going to use a few slides, and I hope you find this interesting and not too long. You may ask, will a cure for Dupuytren's disease ever be found? Well, I don't know, but the answer is maybe. But if it is found, I think the cure for it will be found in a laboratory, not in clinical practice. When it will be found, I don't know, because you never know what new findings will be found in laboratory studies. But there is much laboratory-based and genetic research into the nature and potential ways of modifying Dupuytren's disease occurring in the UK, and this may in time produce a cure to avoid the need for surgery or even radiotherapy. However, for the present time, surgery is the best treatment for established disease where a finger has bent up and will not straighten fully. However, surgery will never be a cure for the condition. In surgery, you heard last month that there are many different treatment options with different surgeons favoring different ones of these, and patients individually preferring one to another. You have big operations which leave a large surgical scar running up the finger and into the palm, where the cord of tissue which has bent the finger up is excised. And at the end, you may even have a skin graft to try and reduce the risk of the disease coming back. And then you have smaller operations which are of quite some interest at the moment, where instead of making a big scar, you make little pinpricks over a finger at sites where the cord, which has bent the finger up, the Dupuytren's cord, is, and you either inject an enzyme, collagenase, into the cord to dissolve it and break it up, or alternatively, with a sharp needle, cut across the Dupuytren's cord at very levels to cut it as you would cut a rope, and then hopefully allow the finger to straighten. So those are the two small operations. As a general rule with Dupuytren's surgery, the bigger the surgery, the bigger the operation, the greater the chance of getting the finger straight, and also the greater the chance of the finger staying straight for many years after the operation. However, the bigger the operation, the longer the recovery period after the surgery, which may be 6 or 8 weeks in some cases, whereas for an injection of collagenase or using a small needle to just cut across the cord, a needle fasciotomy, the recovery period is much shorter, and a week or maybe 2 weeks. Also, with bigger surgery, there is a greater risk of things going wrong in the surgery, which make the hand worse rather than better. And those may be permanent problems which affect hand function from there on, but fortunately, they're not very common. So when you ask which treatment is best, there are many different answers, because it really depends, what do you mean by best? And that varies as to whom you are. And really, if you look at what we call the outcome, the result of a Dupuytren's contracture surgery, there are 3 things which need to be considered, and the NHS thinks needs to be considered. The first is the patient's recovery. So in the short term after the treatment, whether it be injection of collagenase or big surgery, how long does it take to recover? And how difficult is the recovery? Does it mean lots of attendance at physiotherapy and slow wound healing and stiffness of the finger so you can't use your hand particularly well for a while? Or is it, as it is with a needling operation, a needle fasciotomy, very quick, and many people return to work within a day or 2 afterwards? And there's no doubt that the smaller operations do better than the big operations in short-term recovery. So that's where they're best. But then you look at the other thing is, how long does the surgery give you a good result for? We all know that after any treatment for Dupuytren's contracture, surgically that is, there is a risk that the finger will bend up again because of the disease coming back. And if you want a long-term result without the need for further surgery, then you really need to go for a big operation, which has a longer short-term recovery. But as unfortunately, there's no operation at the moment that we know of, or any treatment, which has a quick short-term recovery and maintains hand function for a long period. So it's difficult. And then you've got to consider the person who's paying for it, which is the taxpayer through the NHS. You want something which not only is good for the patient in terms of restoring hand function and allowing a good maintenance of hand function from then on, but also something which isn't so expensive to the National Health Service that it bankrupts the National Health Service, not that this ever would. And this is the problem. Nobody knows what's best for that. If you go for these short-term recovery operations like needling a contracture, cutting across it to divide it. That can be done in a clinic room at a cost of £170. But the problem is, it's almost inevitable that over time, you will need further treatment in the future, which could be the same needling again, or it may eventually require a bigger operation, such that any benefit from having cheaper operations first is removed by later on needing a big operation. So nobody knows which procedure is best for everyone in giving a reasonably short recovery period, giving a reasonably long period after the treatment where the finger doesn't bend back up again due to the formation of a new cord, and one which isn't overly expensive. And there's great debate about that. And at the moment it is being looked at in one study in the United Kingdom and hopefully a second one. At the moment, led by Professor Diaz, who is a surgeon in Leicester, there is a large study comparing treatment with collagenase injections versus standard surgery to see which seems to be the more effective, which patients favor, and what the costs of the two are and how they compare. That study is recruiting at the moment. They want 750 patients or so in it, half of them being treated with collagenase, half by standard surgery. And the patients will be followed up for 5 years to see what happens to them afterwards and compare the results. And that will be very useful. I'm halfway through a grant application procedure for another study, which is comparing the needling, that's the cutting of the cord with a needle fasciotomy it's called, versus standard surgery, to compare the outcomes of those two and see, and in the same way, compare patients' results. We're looking to recruit 400 patients if we get funding for the study, half being treated each way, and then we'll follow them up for 5 years and see how they get on and see what further treatments they need and compare the two. And these are very important studies. There's no doubt about it, but it's difficult to get funding for studies on Dupuytren's disease and other conditions because research is expensive. This study of collagenase is costing £1.8 million. It's being funded by the government through the National Institute of Health Research. The one which I'm involved in is also applying for funding from the National Institute of Health Research and is estimated it will cost about £1.3 million. It's not cheap. And when we apply for funding for these studies to the National Institute of Health Research or other charitable bodies, we're always competing with other studies. For example, we could be competing with studies on cancer, studies on heart disease, or studies on chest infections. And the competition is hard, and we really have to show that there would be benefit from the research to the NHS and patients. I hope I will get my study. I've been working on it for years, but whatever, the first study is ongoing, and it should clarify the position of collagenase. As many of you in the webinar pointed out, different surgeons give different advice as to what is the best treatment and what they would offer, which is confusing. That's because nobody really knows what is best for people, for you to have as treatment. But it is hoped that if we do further studies like this, we will get clarity so that there'll be less difference in what surgeons offer patients, so that there will be more consistency as to what is offered, because people have a rough idea, a better idea of what is best. Obviously, there's research going on in other countries as well, but I'm flying the Union Jack today. I hope you found that interesting. Thank you.